So first, I'll start with an outline of what I'm going to talk about. I have a blog page that I've put up since the beginning of the pandemic, and a lot of this material I've put on that blog page, and I'll explain sort of my motivation and the approach that I'm trying to take there. And one of the common themes in my blog and that I see in this pandemic is sort of the politicization of the pandemic, and sort of two extremes that I call deniers and alarmists, and trying to find the middle ground between them. I'm going to overview what I think are some key things that we've learned from the science about the pandemic that are key about how it spreads, key mitigation strategies, and disease severity. And I'm going to talk a little bit about the mathematics of infectious disease spread that I think is a little counterintuitive to people and important to understand. And I'll hit on several other topics briefly, and we can talk more about any of those during the discussion period. And then I'm gonna finish up by talking about what I think we can expect in the fall and winter and beyond, giving reasons for concern as well as maybe some reasons why things might not be as bad as people are fearing. And then I'll have some conclusions and recommendations and then time for discussion. So with this, as this pandemic kind of descended on us, we're all kind of in the same position that we don't know anything about this virus, this pandemic. And I noticed a lot of rumors flying around, a lot of different information. So I started trying to sort of evaluate what information was reliable and relay it on Facebook to my friends. And I have quite a broad group of Facebook friends, from the most liberal to the most conservative and everything in between. And over time, I got good feedback from those people saying that they really trusted my perspective. And I heard that both from liberal and conservative friends, so that reassured me. So then I started this website and blog to try and provide a more permanent record of the information that I was going through, and hopefully a venue that I could maybe have a broader impact. So that's when I started this COVIDdatascience.com website. And so my philosophy in what I do there is I use the perspective that I have as a statistical data scientist and what I do in my work to basically evaluate the constantly emerging information on COVID-19, filter out the biases, aggregate the information together, identify the key insights that are revealed, as well as the degree of uncertainty in them, and then try to communicate them in an accessible and balanced way. So to date, I have 170 blog posts on a variety of topics. And some of my blog posts are very brief commentaries on an article that I find that I think is interesting, and I just put a few notes on them. And then I have a few longer posts where I go into detail on some key misunderstood and appreciated topics. So in the beginning of the pandemic, I think the seriousness of it was underestimated in the US. And I was kind of in that group as well, where I think a lot of us just thought, well, isn't this just like the flu? Why are we worrying about this so much? And I think what changed people's perspective was this March 16th report by this group at Imperial College that did some interesting modeling. But the result that was really caught everybody's attention was their statement that their modeling found that if left unconstrained, the virus would end up infecting 80% of Americans and killing 2.2 million. So this really raised the alarm bells and motivated the lockdowns that were instituted through most of the US. And also at the same time, we saw horror stories of what was going on in Northern Italy and then in New York, where we saw hospitals overwhelmed and people dying, trucks for bodies because morgues were filled. So that really scared us a lot. And that sort of inspired us to think about this idea of flattening the curve, to try and spread out any of the infections so that our healthcare system could handle that. As a side point, this paper was not really, that wasn't the main result of the paper. And their paper actually estimated about 400,000 deaths in the US if we follow basic mitigation strategies. The 2.2 million number would be if everybody just ignored it and didn't know about it. That's how it would spread. But of course, as people see it spreading, there's steps that are taken to prevent its spread. So they never intended the 2.2 million to be a counterfactual to societal lockdowns, as some people have taken it. Okay, so this led to taking it more seriously. But then I think sometimes some people maybe took it too far. For example, there was this report that came out of this center at Harvard University that had very good information talking about how to end the pandemic and get things under control. But something that they mentioned repeatedly in their report was a call for near universal testing. They wanted 5 million tests per day in order to start reopening. And they thought we needed 20 million tests per day to fully remobilize our economy. So at that time, there was about 20,000 tests per day. And even now, there's only 800,000 tests per day. There's no place in the world that has tested anywhere near that level. So I was concerned when I saw this that this was not realistic and would essentially mean that they recommended indefinite lockdowns. And as we all know, lockdowns cause other damage in society. So I was concerned that this was going too far. So I wrote an op-ed that was published in the Philadelphia Inquirer making this point and sort of making the argument that we needed to identify targeted mitigation strategies since we couldn't keep lockdowns in place forever. But if we could identify the key modes of spread and take those steps to slow the spread, we might be able to keep it from spreading out of control with far less collateral damage to society and kind of find a middle ground. So this kind of showed me very early that there's sort of two sides, as many things in America, on people's viewpoints towards this. So the one side I call the denial or the doubter side. So this side grapples with doubts about the seriousness of the virus, thinking the media has overblown it. There are supporting facts that support this viewpoint. People that have this viewpoint tend to focus on the damage of lockdowns and other extreme mitigation measures. They also focus on the relatively low death rate, especially outside of special groups of people who are older or with pre-existing conditions. And they also may bring up valid points about possible cross-immunity from exposure to other coronaviruses. So there's truth to these supporting facts, but focusing on them at the exclusion of others reinforces their established beliefs, and they could be experiencing what's called confirmation bias. So many people with this viewpoint might consider this virus just the flu. They resist mitigation strategies, and they may fail to understand how fast it spreads, the damage that unconstrained spread can bring to society, and other long-term effects of the virus. So some people seem willingly ignorant, or at least that's how people on the other side view it. But many people simply have serious doubts and distrust the media reports, perhaps, in a valid way, knowing that the media does tend to sometimes cause alarm on issues. It pays off. So it's important not to be dismissive of this group, since if we're going to successfully have mitigation strategies, everybody needs to be on board. But that's not sort of the other extreme. There's another extreme on the other side that I call alarmists that understand the danger of unconstrained spread, and they're aware of the damage the virus can do. There's facts that support their viewpoint about how alarmingly fast the virus spreads, much faster than flu, and they recognize the societal damage that it can cause if it surges out of control. It is far more damaging than the flu, more deadly, and there's more complications and long-term effects. And they recognize that society and the economy won't get back to normal as long as the virus is not under control. But again, there's truth to these facts, but if they focus on them at the exclusion of others, it might reinforce their beliefs, but they might not be looking at all the information. They may also have some confirmation bias. So people that are at this extreme may be focused solely on infectious disease control, favoring more aggressive mitigation strategies, but might not account for the potential collateral damage that these can induce on society. And so they also might overestimate the ability to control the virus, not recognizing the need for sustainable strategies. So another group that I would sort of characterize as maybe going too far on that end of the continuum is a group that's called Refuse to Return. That was a group of teachers that said they didn't want to return to school campuses until their counties had no new cases for at least 14 days. Well, knowing what I know about tracking county level infections, almost no county would reach this anytime this year, maybe not next year. So taking this sounds safe, but it's just not realistic. So we have to look at the whole picture. And some people that are at this extreme might have an irrational fear of the virus, considering that any risk of transmission is too great. We have to do everything we can to keep it from spreading at all. So media and scientists, including me, tend to be in this group. And I think we have to watch our blind spots about thinking of our assumptions. So what I've tried to do on my blog and in my own analysis is to recognize that these two extremes have their problems. And like a lot of things, the truth is kind of in the middle. And so to try and figure out how is the best way to pull all of the facts together, set aside bias, and evaluate and aggregate all that information together and figure out what's going on. So one of my blog posts talks about just sort of this idea of these two sides. So looking at the information that's accrued scientifically that I consider reliable and clearly shown, how does this virus spread? Well, we've learned that the main vehicle of spread is through respiratory droplets that are exhaled. When people exhale, they can exhale the virus in droplets of different size. The larger droplets are called respiratory droplets, and those are heavy and fall to the ground quickly within 6 feet. So this is a lot of the reason for the 6-foot social distancing guidelines. But there's also aerosol droplets that are much smaller. They're capable of staying in the air and traveling a longer distance. They have a lower viral load, but in some settings they can accumulate in the air. So this was finally acknowledged by the CDC as a potential mode of spread, but considered secondary to respiratory droplets. Then fomites is basically viral particles on solid surfaces. This is why we early in the pandemic, we obsessively cleaned everything, thinking this was how we were going to get the virus. It turns out that's not a primary way. We still need to do these things, but the respiratory droplets is the primary mode of spread. The others are secondary. So some other things about spread that are important is viral dose is important. So we have to think about viral volume and length of exposure. Being exposed to one molecule of the virus doesn't automatically infect you, but having a larger exposure and over a longer period of time makes a big difference. Also, there's a big difference between indoor and outdoor. The virus spreads much more efficiently indoors. Okay, the weather also has an effect. Cool, dry weather, the respiratory particles travel much further and live longer in those conditions. We've also learned that this virus is characterized by super spread, very different than flu. In flu, people kind of spread evenly. Like if you're infected, you're about equally likely to spread. Where here, a small proportion of those infected seem to cause most of the viral spread. And so a lot of the spread is caused by super spread events. So getting those super spread events understood and under control is a key strategy. The timing of the spread, the most infectious time appears to be just before and just after symptoms are shown, up to maybe 5 days. And because a vast majority of the people are asymptomatic or with only mild symptoms, that means that most of the spread is occurring from people that are asymptomatic or pre-symptomatic with either no symptoms or mild symptoms. So it's hard to detect when someone is sick. This characteristic is part of why this virus has spread so out of control, because most of the people spreading it don't know they're sick and others don't know they're sick. And it spreads very rapidly. The underlying mathematics of exponential growth means that a novel virus to which people don't have any immunity can spread out of control very quickly, especially if testing is inadequate. So I'm going to talk a little bit about the mathematics of exponential growth quickly here. One thing we've seen is people let their guards down when they see low viral numbers, thinking that it's not serious, but they don't realize that the mathematics of exponential growth means that if you don't show vigilance, it can grow out of control very quickly. Like an example is Israel, where by mid-May, they got their cases down to less than 10 per day in the entire country. But then they opened up somewhat recklessly without showing caution. And now they're at a level per capita that is about 2 or 3 times what the US is. They almost had it all the way down, but they let it grow again. And the reason for this is because of the concept of exponential growth that drives infectious disease. So I just want to overview some of this. I think it's a good background for all of us to have. So there's a concept in infectious disease of the reproductive rate. And what that number is the average number of people infected by each infected individual. So you might have seen this R sub 0, which is kind of the natural reproductive rate. It's a constant for the virus that represents if you don't do any mitigation strategies, what is the fixed number, roughly the average number that are infected. For SARS-CoV-2, the virus that causes COVID-19, it's about 2.5. Then R sub t over time t is the actual reproductive rate at a given location and a given point in time. This depends on community factors, the population density, the age distribution, the weather, plus individual behavior. How crowded are people together? What is their distancing? Are they wearing masks or not? And so I've been collaborating with a group that's a collaboration between CHOP and Penn called the Policy Lab that's doing modeling of this and identifying hotspots. And this modeling is being used by the White House pandemic team to sort of identify the hotspots. So we've learned a lot about what factors affect the community level spread and have successfully predicted some of the outbreaks that have happened. So another important thing regarding the mathematics of spread is this idea of herd immunity. So what herd immunity is, the idea kind of arose in the context of vaccines, where the goal is to get to a point where enough of the community has immunity, hopefully through vaccines, so that the virus can't spread in an epidemic fashion anymore, because too many people that it finds are going to be immune to it. And so it depends on this R0. So if R0 is 2.5, then 60 or 70% of the community needs to be non-susceptible or immune in order for herd immunity to kick in. Now, one thing is it's very damaging to try and seek herd immunity through infection in terms of hospitals and death. So that's why we're working so hard to get a vaccine. And a vaccine is not a magic bullet. It works by building herd immunity in a safer fashion with the speed of the effect depending on how well it's delivered, how efficacious it is, and whether people actually get it or not. Okay, so just to show, I'm just going to show an illustration of how this mathematical growth can work. So here, let's say we have a community that is 1 million people, and we start off with 1,000 cases, and we don't do anything. So we let it spread by 2.5. This is the level of spread we see. From 1,000, within a month, we're up to about 30,000. Within 2 months, we're up to about 230,000. And then if you measure the expected hospitalizations and death, in this community, we'd have a peak of 74,000 hospitalizations and a large number of deaths. So this is what happens even if you start with a relatively low number, this is the base of an exponent. So it will grow very quickly out of control. And that's what we saw in New York early on. And that's what we saw in Italy very early on, because they didn't know anything was going on. Now, if you take some mitigation strategies, what those do is it effectively reduces the RT. So if you reduce it by 1/3, you're going to stretch it out where it's going to take several months, but it's still going to grow up to that level and still give you a peak number of hospitalizations that are too high. If you can get a 50% reduction in the R0, then it really spreads it out over time, but it's still going to continue to grow. But the goal is really to get it down below 1, which would be a 60% reduction. If you do that, you're going to keep having cases, but you keep it relatively stable. The hospitalizations are never going to be high, and you're going to have fewer deaths in the long run. And then if you can get the RT below 1, it will eventually die out and get to a very low level. And so what we're really trying to do societally is keep it sort of under control until we have a vaccine. And then when we have a vaccine, that will effectively reduce this R sub t more and hopefully get down to the point where we have herd immunity. So that's kind of some of the mathematics behind it. So I want to mention a couple other points here. So based on how it spreads, what should we be doing to keep it from spreading out of control? There's a couple things that we talked about early that are important but not sufficient. Fever checks and staying at home when sick are important, but it's clearly not enough since most of the people spreading it are asymptomatic. We also did a lot of disinfecting and talked about avoiding touching your face. Again, that helps, but that's not the main thing. So we don't have to be a germaphobe and disinfect every single thing we touch. We just need to, avoid touching common surfaces and practice good hygiene. But some of the key strategies that do make a big difference is physical distance is a key. When we're around people, staying a longer distance, just in case someone's exhaling respiratory droplets to reduce the risk of getting it. Masks are also a key tool. It's not enough, but especially because of asymptomatic spread from exhaling, if most people wore masks, then a lot of the asymptomatic spreaders, the mask would keep a lot of that virus from being exhaled into the air and reaching other people. And there have been scientific studies that have shown that mechanistically, and epi studies showing that it helps. The mask will not be sufficient to completely keep you from getting infected, but again, it will help reduce that RT. So aerosol spread, again, is not a major risk, but in certain situations, it could be a real problem. So if you're in a poorly ventilated area with recirculated air and with crowds, then you can have super spread events. So aerosol spread may be feeding some of the super spread events. So you want to avoid spending long periods of time in crowded, enclosed indoor settings, especially if poorly ventilated, and even more so if there's forceful exhaling. People either talking loud, shouting, singing, all of that exhales more particles. Also encourage outdoor gatherings, much lower risk of transmission. So lockdowns do help get the spread down very quickly, but those can only really be temporary measures. We can't have them as a sustainable measure in the long term, and people eventually get worn out by these and then sometimes don't even want to follow these other steps. Then if viral levels are low enough and we have access to fast testing, then testing, tracing, and isolation can really manage things and keep it under control. So that's really our goal, is to get it low enough to do that. Okay, so I don't want to take too much time on this, but I just want to mention something about disease severity real quick. So in terms of disease severity, we see that a vast majority of people have mild or moderate symptoms only, or are asymptomatic. Only 20% or so are severe, and only 5% are critical. And older people and people with pre-existing conditions are much more likely to be in these other groups. But one of the tricks about this virus is that the virus itself isn't what does the most serious damage in these cases. What it is the immune response that gets sort of out of control and causes something called a cytokine storm, which is a type of inflammatory response that can cause multi-organ damage and all kinds of problems. This is what leads to a lot of the deaths and severe disease. It's also what leads to some people being long haulers and having symptoms for a long time, and also is the reason why some people even that have mild and moderate symptoms are showing long-term organ damage, like inflammation of their heart. So these are some reasons why we have to be cautious, even though the death rate's low. So one other thing I'll mention real quick is we've seen the death rates come down in the summer quite a bit from what they were in the spring. There's several reasons for that. Some people have speculated, oh, maybe the virus has evolved to become less severe, but there's literally no evidence of that. They've looked at that, but not. A bigger reason may be the younger demographic that tended to be driving the spread in the summer, improved treatment strategies, maybe some partial immunity from previous effect on the viral load exposure, that in the summer, the spread is not as efficient because of the heat and humidity, but people can still get infected, but maybe with lower viral levels. But now as we move into the cold season, it's possible that will reverse and we will see more severe disease. So another reason why we have to be careful. Okay, so I'm just going to briefly mention some other topics on my blog, and you can ask questions about these. I can talk about these, or you can look at some of my blog posts. But some other things I've tried to do is dispel conspiracy theories and myths that have come out. The pandemic video I picked apart, the notion that it's just a flu, the idea that masks harm you or don't work, the idea that we're close to herd immunity now, the idea that deaths attributed to COVID aren't really caused by COVID. And there's also a guy, Ivor Cummings, that I kind of picked apart. His argument, he has some good points, but he goes to some extremes. So, but I feel very confident in dispelling these. And you can see on my blog post why I really believe those are true. But also, I talk about understanding the importance of each data type and its limitation. There's cases, testing positivity rate, hospitalizations, and deaths. Those are all kind of important, and there's various sources you can use to follow those data. The Johns Hopkins website, the Policy Lab website that I collaborate with has a really nice display that has county level numbers. And then also I have an app, COVID Track, that my student has put together that allows you to compare different states and countries with respect to these measures. Also, it's important to understand the different types of tests. The PCR tests are the common tests that are used, that are the gold standard, but they do have some weaknesses. There's antigen tests that are faster, that are being increasingly used, but maybe not as sensitive. And then there's also antibody tests that don't test whether you have active infection, but test whether you were previously infected. And those are good for assessing the prevalence of how many people have been infected in the society. I've also talked about this idea of wartime science, the idea that we can't wait for the usual pace of science, which would take many years to develop a vaccine or new treatments. We need to accelerate it, but there's hazards in doing that. And we've seen that. We've seen retracted papers, bad information getting forwarded and used. So we need good quality control in the scientific community to counteract that. Also, immunity in vaccines. I have a lot of recent posts on that suggesting a certain percentage of population perhaps has been infected so far, somewhere between 10 and 20%, maybe a little more than 20%. But there's also some other immune concepts of B cell memory, T cell response, cross immunity that are kind of important in helping us think about what we can expect moving forward and how long it's going to take us to reach herd immunity. And also about the vaccine efforts. There's also a couple really good information sources I recommend besides my blog. There's Michael Osterholm is an epidemiologist from Minnesota who's right on point, I think, with a lot of his stuff. And there's internet guy, ZDog MD, who's a doctor who also just puts out great information, very accessible. And I agree with almost everything he says. He kind of finds the middle ground. So what do we expect moving forward? You've probably heard a lot of discussion that we're very concerned about a second surge in the fall or winter, or about things getting much worse. And people are generally very concerned about that. Most experts think that the fall and winter will get much worse. And so I'll mention some of the reasons why we think that, and then I'll go to give some other reasons why it may not be as bad as many people think. So first, the pessimism. So why would it be bad in the fall and winter? Well, people will begin spending more time inside as the weather gets colder, especially in the northern United States. Notice that the surge that happened in the summer was in the South, where it's too hot to be outside much and people were indoors in air conditioning. We've spent more time outside here in the Northeast, but now we're seeing in the Midwest and Northeast, we're seeing sharp upticks in cases as people are spending less time outside, and that's just going to increase as it gets colder. Also, we know the virus spreads more efficiently in colder, drier weather and may potentially lead to more severe disease. Another thing we worry about is when flu season comes. Flu puts a lot of people in the hospital already. So when you add to that COVID-19, there's worry that the healthcare systems could become overwhelmed. And that's part of why there's a big push to get flu vaccines this year. There's potential for more spread. People are less isolated now than they were earlier. Kids are in school and moving to school in other places where it's been closed. Colleges are open. More businesses are open. Also, people are experiencing COVID-19 fatigue and anger. They're getting sick of just all of these restrictions, and some people are getting really angry that don't think they're necessary. But both of those are contributing to people showing less vigilance. And of course, our country is as divided as ever, and that's certainly not getting any better this fall. And our national leadership hasn't provided clear communication of this emerging evidence. Like some of these things that I'm presenting, that I can solidly say that we've clearly learned them. I don't think they've been clearly communicated as well as they could be by our national agencies. And there have been some cases of people getting reinfected within 3 months or so. So that's raised concerns about whether immunity is durable and whether a vaccine could work. Also, we're not close to herd immunity. We need to get to 60 to 70%. We're maybe 10 to 20%, maybe a little more. It depends on how you count it, but we're not that close. And vaccines are not guaranteed to work. And more than half the people surveyed say they don't feel comfortable taking a vaccine right now. And part of the reason is that they may rush the vaccine before it's ready. And there's many under development. But if they rush one that's ineffective or unsafe first, there could be a big backlash and people won't want to take the ones that do work. And if you look back in the 1918 pandemic, the pandemic waned in the summer, but then in the fall and the winter, there was a very strong second surge that was worse than the previous year. So, many infectious disease experts, including Dr. Fauci, have sort of looked at that and said, well, is that going to happen this time? Okay, so that's a lot of bad news, but it's not all bad. There's a chance that it won't be as bad as many predict. And so some of the reason is, I mentioned, at least in the southern US, they're going to start moving outside more in the fall. So they may have better conditions, less time indoors. Also, all the things we're doing with distancing, masks, and improved hygiene will almost certainly lead to a historically late flu season. The flu spreads about half as efficiently as the virus behind COVID-19. So all these things we're doing, flu doesn't really have a chance. And we've seen this in the Southern Hemisphere. Their flu season happened, they had very little flu. Now, some people take that as to mean that COVID-19 isn't real, it's just the flu, it's being made up. Absolutely not true. You can sequence the virus, you can see exactly what it is. SARS-CoV-2 is a totally different virus than the flu, so don't fall into that. But this is part of the reason why we're not seeing flu, because of the things we're doing. We haven't seen widespread transmission in school yet. This is a good thing. And our policy lab group is really working with schools and recommending that more and more will open, but with caution, but opening. We haven't seen widespread transmission in most. Colleges do have widespread transmission, but some of them might be developing local herd immunity. I have two daughters at Auburn University, and they both said every person they know has been infected. And so they may develop sort of herd immunity among that local population, so that there's a worry that they're going to bring it home to their family, but by the time they come home for the holidays, they may be well beyond being infectious. Also, we might be closer to herd immunity than many think. I mentioned that I have a blog post where I argue that there's somewhere around 20% or a little bit more that already show antibodies for the virus. And there are papers that suggest that there might be another 10% that have developed T-cell immunity after exposure. And then there's other studies that suggest 20 to 50% of the population may already have T-cell response from previous coronavirus infections, from coronaviruses that comprise part of the common cold. Now, a warning sign about all of this is a lot of this T-cell immunity might not keep people from getting infected or spreading it, but it might predispose them then to be the ones that have mild or asymptomatic disease. But we might be closer than people think, because we really don't know fully how the immune system is exactly working and how it affects infection. Also, even though there have been reinfections, it's been very rare. There's only 10 or so confirmed in the world. We would expect hundreds of thousands of them if everybody lost their immunity within 3 months. So we're not detecting all of them, obviously, but I think it's very clear that most people are immune for longer than 3 months. The public and businesses know better how to mitigate spread. There's better procedures in place to reduce crowds, practice distancing. Mask wearing is more common. It does help. The disease is less severe now. I mentioned it might get worse in the winter, but it might not. It might be that the reason why disease is less severe is because we figured out how to treat it better, and maybe people have a little more immunity that allows their system to fight it better. It's not as novel to them. So that's possible. And also our treatments have improved, especially for severe disease, because I think doctors have learned that the seriousness of it is not the virus spreading. It's once it gets to a certain point, it's your immune system and that inflammatory syndrome. So they know how to treat that better now with dexamethasone and other things. And that saves a lot of lives in the advanced ones. So we also have better access to testing now. So it's possible to do fast testing and tracing and targeted isolation. And there's many vaccines under development. It's progressing in record time. And I think there's a good chance that we'll see a vaccine that seems safe and effective to start being distributed by the winter. Okay, so in conclusion, what do I think will happen between the optimism and pessimism? I mean, of course, I don't know, but I expect there to be a surge in the winter, especially in the north, but maybe not as bad as expected. I expect the severity of the disease to uptick from the summer, but again, maybe not as bad as the spring. I expect to have a vaccine that is going to start getting slowly distributed. Hopefully they don't rush it too much, like in the winter and spring. I believe schools should be open, and they should be using the fast tests and tracing and isolation to keep things from spreading out of control in the schools. And I think businesses also can open a little more, but places that can do telework, it's a good idea to do that and be careful, because we can keep the viral spread down. So I think we have to prepare for the long haul. Dr. Osterholm calls this a leaky bucket virus, meaning that you think you have it under control, but then it's always going to leak out and start spreading again. So we have to keep that in mind. It's a long-term battle. So there's no magic bullets. It's just going to make it go away. So the key thing is we have to remain vigilant. And the biggest thing is to avoid spending long periods of time in crowded indoor places, especially if enclosed and maybe poorly ventilated. And then when we're, especially when we're indoors or close to people, practicing some physical distancing and wearing masks. We need to keep doing this as a society. If we do that, we can keep it under control. But we need to stay connected. Even as we're physically distanced, we need to stay connected socially to people, get together outdoors as possible, and don't give in to the despair, that you hear. There's good reason to believe that things will get better. It's going to be a tough year. Things won't be back to normal anytime really soon. Maybe next year they will be. But also maybe take the opportunity to evaluate and adjust priorities in life while we're in this period where our usual things are disrupted. It might be a good opportunity for us to evaluate and reset our priorities, and also to be sensitive and help others in need. This pandemic's affecting all of us, but for some people it's absolutely devastating. And so I think it's a good time to be more aware of people around us that might be in need, and it's a good opportunity to reach out and help those people. So, okay, went a little longer than a half hour, but I'm glad to take any questions and have any discussion. And I guess we can do this multiple ways. People could type in the chat. And I think there's also a way people can sort of raise their hand.
Dr. Morris, one question has come in, which I'll start you off with, but also anybody that would like to, they can unmute themselves and ask it out loud, or again, they can chat it to me if they like. But the first question is this, and then we'll just kind of hang on here for a few minutes past the quarter after if there's some additional questions or something more detailed that you'd like to ask Dr. Morris.
I'm just write this down. Yep.
Yeah, I'm thinking that people are going to sign off when they need to, but we'll hang on if they're able to. So the first question is this: what from a statistician's point of view, what do you think would have happened in society if we publicized and researched the flu to the same degree that we have done with COVID-19?
Yeah, that's a good question. I think, well, one thing is, I think we'd realize the death rate for the flu is far, far lower than what we say. Like, the death rate for the flu, I think, is reported as 0.1%. But I think a vast majority of the people with the flu never get counted as having the flu. So that's an important distinction in terms of mortality, that there's the case mortality rate, which is the number of confirmed cases who die. And then there's the infection mortality rate, which is the number that actually get infected, including those who are not tested and confirmed who die. So what would happen is, if we have a certain number that we say have the flu in a given year, there's probably a lot more that were not detected. And so the death rate is probably much, much lower than that. And that's true for COVID-19 as well, that I think in the US, the case mortality rate is 3%. So 3% of people that are confirmed cases have ultimately died. But I think that the infection mortality rate, when you include the fact that only about 1 out of every 10 infected are really confirmed positive, then it's more like 0.2 to 0.6% death rate. So that's one thing. But also, I think if we talked about it a lot, we practice some of these same measures in flu season of being aware of distancing, washing our hands, maybe even wearing masks in crowds. They do that over in Asia. And if we did that, we would actually save a lot of lives due to flu each year. But flu does spread less efficiently, and its R sub 0 is much lower than COVID-19. So that's one of the big differences. So I guess I could say more, but if anyone has specific follow up to that, I can talk about other aspects as well.
Any other questions? Go ahead, and if you have any and you'd like to unmute and ask them. Looks like we still have about 50 folks online, so now would be a good time for that. While you're thinking or while you're unmuting, I will let you know that this presentation today has been recorded. There were a lot of websites and sources and for information that were referenced. If you'd like to get a copy, once Zoom has done its magic and it's compiled, I'm happy to email a copy out there. Just email me at glo@messiah.edu and I will get a copy of the presentation to you. But any further questions for Dr. Morris today?
So I see one question. How do you chat with family if they're in the denial or the alarmist side? I mean, I do this all the time because I have many friends on both sides, and I try and I try and kind of be in the middle or be in the space where I think the data supports. And so one thing is, I know that when I post something, some of the posts the denier people like, and some of them the alarmist people like. So the fact that one side is not always liking my post reassures me. But what I try to do, though, is connect with people, because I mentioned some of the facts that support those sides. Like, I always affirm the facts that support their side and show that, okay, there's some merit, you know, to your perspective. But then I help them see what some of the blind spots are that they're missing. So with the alarmist side, they might not be thinking as much about the fact that this is a long-term battle and we have to have sustainable strategies. And something like a lockdown, you just can't have longer, it does too much damage. And people on the denier side underappreciate the key differences with the flu and the very serious things that happen. And when they look at the data and say, oh, it's not that bad, they don't take into account that the whole world has literally shut down and we've still had this much spread and death. So what would it have been if we would have just ignored it? It would have been way, way, way worse. We know that. So, you know, so help them see the facts that they're not considering. Okay, so I see another question about people of color are more susceptible to COVID. Do we know why this is? It's most likely has to do with exposure, because actually any people who are not able to work from home are going to be more exposed. So there's people that are so-called essential workers, or they're working in businesses where they're not going to get paid unless they go in hourly work. And so those people are more susceptible to getting infected. And so that's something we've seen also in our antibody studies. I collaborate with the group at Penn, and we've checked the infection rate throughout the city in pregnant women. In Black women, it was about 10 times higher. Actually, Black and Hispanic women were about 10 times higher in infection rates than it was for white or Asian women. So I think that's the main thing. They haven't found any genetic reason for this. It could also have something to do with comorbidities, obesity, diabetes, high blood pressure, asthma. Those are all things that put people at higher risk for worse outcomes. So any group of people that have a higher rate of those comorbidities is also going to have more severe disease and death. Okay, so what states do you think manage COVID the best and worst?
That came in along those lines. What do you think? Response. Maybe you can answer the two of those together.
Oh, what's that other one? I'm sorry.
What do you think of Pennsylvania's specific response?
I think Pennsylvania has done a great job. Like, early on, I felt like they were being too alarmist. I felt like we could have opened sooner than we have, but I think they've found a good balance between the two sides. And I think that's borne out in the numbers. Like, New Jersey, New York, and Connecticut had that massive early surge. It started spreading to Pennsylvania, but we shut down. We shut down a week before New York City did. And I think that prevented that huge early surge from hitting us. Otherwise, almost certainly it would have. Like, we saw it in our University of Pennsylvania hospitals. The ones in New Jersey started getting a massive surge, but the ones in Pennsylvania did not. And so I think that helped. And so I think they've kind of found a middle of the road option. Honestly, I feel like I wish there were more that had a moderate response. I feel like it's a red blue thing. I feel like the red states have been too reckless, and I feel like the blue states have been too overly cautious. And I see that with the school opening decisions. Like I still have tons of friends in Texas and helped, some of the schools there think through this. And I feel like they're just like, this is nothing. We're just going to open up. We don't want to make a lot of changes. And there's some, but you can just see that there's not a seriousness there. And their viral levels were very high at opening. Where then here in the Northeast, even though our viral levels are much lower and we're in a better position to open, there's much more hesitancy to open schools. And I feel like they've been a little slow. So I think that, all the states have to be aware of all the facts and try and find a middle ground. But I do feel like Pennsylvania has been among the best. Okay, so let's see. So a few others. So let me go. Yeah, which was that?
Pennsylvania do you think have done the best with mitigation?
So which states other than Pennsylvania?
Yeah.
I would say, New York has done a great job because they were so high and they finally got it under control. They had a lot of missteps early. A lot of our northeastern states did a terrible job protecting people at nursing homes, and New York was slow to react, but then they took a really strong response. They've been praised for getting it under control. But I think what really depends is, as they open, are they able to keep it under control? But yeah, I think it's hard. It's hard to really say that I like what any states have done, because I feel like some of them, like I said, have been too hesitant, and they've had some rules that don't make sense, that restrict people in ways that don't help. And then a lot of other states, like Florida, opening everything and taking away all restrictions is, very reckless thing to do. It might be inviting a lot of problems. But they've had so much virus already spread, maybe it won't be as bad, who knows. But jumping over to California, I see one question saying about recommendation to put your mask on between bites of food while eating out. Masks really help, but they're not enough, and it doesn't mean we don't distance, and we have to wear the masks right. And what bothers me more is when they say you have to wear masks whenever you leave your house, even if you're outside alone. That makes no sense. Even if you're indoors walking in a big open area and no one's around you, to me it doesn't make sense wearing the mask based on the data. But whenever you're in a crowded group of people, wearing the mask is important. So with restaurants, it's a tricky thing, because I think it depends. Like a lot of our restaurants in Pennsylvania have had mostly outdoor seating and much reduced capacity indoors where you have good spacing. So if you have good spacing, then it might be okay. But putting the mask on between bites of food, that is kind of annoying. But one problem is, if you're in a restaurant that has poor ventilation and you have too many people inside, that could be an environment where there is a lot of spread. But again, I don't know if the masks are going to completely prevent that, but I think it sort of depends. So another question. Oh, go ahead. Yeah.
Looks like a follow-up question on something that you addressed a little bit in the presentation, and that is, your gut is, would there be another wave of coronavirus coming in the end of fall, early winter?
Yeah, and I think, and I said a little about that, but I think in terms of nomenclature, I don't think there'll be a second surge, but I think that the places that did not really have a first surge are more vulnerable because their population has not been as exposed. Some of these places in the South have had maybe 30, 35, maybe even 40% maybe exposed, perhaps, or at least like 25, 30 in the really, really hard hit areas. So that's going to really slow spread. But in the Northeast, because we've done such a good job with distancing, we also are more vulnerable to spread. And so I think that we're seeing it now, like Wisconsin, Minnesota, Indiana are starting to surge way more than they ever have before. So I think in Pennsylvania, we could be vulnerable to that if we're really careless. If we're not careless and we keep practicing basic mitigation and showing vigilance, then I think we can kind of keep it under control, even as we go in the fall and winter. But it all depends on the public's behavior and getting everybody moving the same direction. And that's part of why, like, I want my blog to be apolitical, but because I think the political divisiveness in our country is one of our biggest problems in managing this pandemic. Because when you really look at it, every person on the right or the left wants the exact same thing. Nobody wants people to be sick and die. Nobody wants things to stay closed or kids to be home from school. We all want the exact same thing. But because of our divisiveness, we can't even talk rationally to each other with different viewpoints and try and figure out what is true and agree to act on it. We can't even do very basic things. Everything is like a fight. And I think that's our biggest problem in this society in many ways, but especially in terms of this pandemic. So I think the key thing for our state and any other state is, can we come together and agree, hey, let's do these basic things. It doesn't cost us much. Let's just be mindful of doing these things and get everyone to agree. And if everyone does that, I think we can keep it relatively under control and not let it surge and not have the spikes in hospitalizations, not have people have to talk about doing another lockdown, and hold out until hopefully we have a vaccine. And then if we have an effective vaccine, we can knock it down to herd immunity and then really get back, to more normal life.
Just one more question that came in directly to me, and that is this. Since there's so much variance in the virus between climate areas, would there be any valid reason to have a national response, sort of national response in quotes?
Yeah, and I think it depends what you mean by national response, because it makes sense. Like, to me, it always makes sense to customize the response to the situation. A big city has to take more precautions than a very rural, spread out area, right? Colder climates in the winter need to take extra precautions because people aren't outside. The summer, when people are in the air conditioning, you need to take special precautions. When it's a vacation destination and you have lots of people coming in, or you have like a big rally or something, you have to take precautions. So I think you got to customize to that. But I think having a nationally coordinated response would be a great idea. And part of the reason is the virus it spreads like crazy. It goes where it wants, it goes where it's allowed. And so if you have part of the country that lets things spread out of control, it's going to spread to other places. So we do need some sense of national coordination. And I think a key thing is, like, some of the things I tried to present here are the things that I view as kind of established facts that are very well supported. And I think if there was some way that we could come to an agreement on some of those key facts and have it communicated from a source that has respect from people on the left and the right and is regularly communicating, it would go a long way in getting us to have a more coordinated response and getting people to move in the same direction. Because really, the tragedy is, if we all did some small things, we could keep this under control with relatively little pain. But because we're so divided, we're not doing that. And that's causing all the problems, really, on both sides. It's causing spread to be more out of control than it is most places in the world. We're having a much harder time controlling it. And then that's also feeding the people that believe in lockdowns, and because things are spreading out of control. So really the best way to avoid lockdowns is to do the small things to keep things from spreading out of control. So anyway, I think we do need to be more united. And I think I wish our national leaders or scientific leaders or somebody could really take that mantle of communicating this information. Because one thing is, it was a novel virus. We knew almost nothing coming into this. So some recommendations and facts have changed, of course, because we knew nothing. Now we're learning. And that makes people distrust what they're hearing. But if they think about it, they should expect that. I mean, as we learn more, some things are going to change. We didn't get it immediately right. But if we had someone transparently explaining what we've learned, and when recommendations change, explain why they've changed. You know, not treat people like children, but, you know, treat the country like adults and explain and be willing to be transparent and don't be afraid of giving certain information, then I think that would go a long way.